Good evening, everyone. Today, our point of discussion is about Damon and TADS going beyond the envelope of discrepancy, defining moments in orthodontics, and game-changing aspects. We need to understand that this is the time in which orthodontic surgery, like orthodontics, is becoming extremely popular with TADS and the self-ligation system. And this is one case that is going to make you convinced that anything is possible with these form of treatments. So this is a patient who comes with a severe gummy smile. She's 26 years of age. She's a female, and she has spacing in upper and lower anteriors, apart from a vertical maxillary excess, as you can see precisely that she has anterior as well as posterior gumminess. She does not have any specific medical history. So if we look into the pre-op photographs, the extraoral photographs, we see that there is a midline discrepancy. Apart from that, there is severe proclination of the upper and lower anterior teeth, and there is spacing of upper and lower anteriors also. So she also has increased incisal show at rest, and on smile, she has extreme gumminess. You can see that there is about 8 to 10 millimeters of both anterior and posterior gumminess. And these treatments are basically in the past would require orthodontic surgery. But it is definitely possible to get treated with TADS these days, and we are going to show how is it possible. So this is how the patient started with. So if you look at the 45-degree view, you would come to know that there is severe gumminess. You can see anterior gumminess, posterior gumminess. There is a lot of black, dark triangles that basically increase buccal corridor spaces. Apart from the fact that she has proclination of the upper and the lower anterior teeth. She also has a clockwise rotation of the mandibular plane due to a vertical maxillary excess. Her lip incompetency at rest is very, very prominent. She has a convex facial profile, and incisal show at rest is maybe about 7 to 8 millimeters. So that's a severe case that as severe a case that we can treat with Damon and TADS. So when we look at the intraoral perspective, we find that it is a class 1 skeletal base. It's a class 1 molar and canine relationship with proclination of upper and lower anterior teeth. However, she has 100% deep overbite. As you can see, the lower incisors are touching the palate, and she has increased overjet too. So as far as this the case progresses, you'll see that the occlusal view shows that there is proclination of the upper and the lower anterior teeth, and there is significant amount of spacing also. She has a full complement of teeth, both in the upper and the lower anterior teeth, as apart from the fact that she has a bit of dental caries, which needs to be attended to. So when we look at the OPG, we notice that the third molars in the lower arch are impacted. Probably then from second molar to second molar, we have to attend to. And that's because now our terminal hinge for orthodontic treatment is the second molar. So the third molar extraction might be omitted at this point of time. There is a great advantage when the upper third molars are missing also, as in this case. So you have an occlusal plane, and the terminal hinge of occlusion is basically the second molar now, not the third molar. So when we impact the dentoalveolar impaction, we need to take care that we bond up and bracket up all the second molars, and we bracket up all the teeth ahead of it to get full arch intrusion of the maxillary segment and a counterclockwise rotation of the mandibular segment, which would help in improving of the convex facial profile. You can look through this article written by us in a university journal on skeletal anchorage mediated slow auto rotation of the mandible, orthodontic surgery like orthodontics for correction of vertical maxillary excess with TAD open hyrax combination system. And this will give you an overview of how we actually treat such very, very complex cases. We also would love to let you know that the OPG showed that pipette-shaped roots of the maxillary, central, and the lateral incisors, which have and may be prone for root resorption if at all we don't follow the biomechanics well and doesn't have enough control over the force that is being applied for intrusion of the maxillary segment. So what is the role of the third molar in the autorotation of the mandible in such cases? As you can see that there is a severe proclination of the upper and the lower anterior teeth, but the third molar consideration is very unique in such cases. We have to note that in the first scenario, okay, when the third molar is missing, your terminal hinge is the second molar. That's a great situation. In that case, only 4 premolar extraction might be enough, and you don't have to extract 8 teeth. However, you also have to note in certain scenarios when the third molar is also present, like in the second case, and the autorotation is happening and you are getting good results with maxillary impaction, you might delay the third molar extraction. But if you see that autorotation is not happening when you are impacting the maxillary dentoalveolar segment, because of a terminal hinge, which is the third molar, you have to extract the third molar, apart from the 4 premolar extraction that you are doing in such cases. But in this case, we are lucky that we don't have to extract the upper third molars and the lower third molar are impacted. And then we can go ahead with a 4 premolar extraction only. So if we look into the cephalometry, we can see that there is severe proclination of the upper and the lower anterior teeth. There is significant amount of lip incompetency at rest. So the interincisal angle is huge in this case. So when we do a composite analysis, we see that there is good amount of proclination apart from a vertical maxillary excess that we note, and there is extrusion of the upper incisor teeth, which is causing a lot of gummy smile. Do a tracing, we understand that it substantiates the previous findings of proclination of the upper and the lower anterior teeth and the vertical maxillary excess. So let's see the numbers. So when we look into the cephalometry, we see that there is increased SNA angle of 84 degrees, and the SMB is also increased. The NB is increased probably because of a clockwise rotation of the mandibular plane angle. And we have interincisor angle, which is reduced, which shows that there is significant proclination of the upper and the lower anterior teeth. The inference of the overall cephalometric parameters shows that there is increased convexity of profile and there is a skeletal discrepancy associated with this dentoalveolar problem. So what is the net inference? The net inference is that we have a class 2 skeletal base, basically because the NB angle is more. We have a vertical growth pattern in this patient. We have procline upper incisors, we have procline lower incisors, and we have a severe convex facial profile. Apart from the fact there is a significant amount of gummy smile, and if you do a Burstyn-Cox analysis, we'll be able to find out that the maxillary anterior dental height is 44 millimeters, which is like huge, and the maxillary posterior dental height is also increased. So it is not about the impaction of the maxillary dentoalveolar segment, but is a full arch impaction that is required to get an ideal result in this case. So what is a treatment plan? A treatment plan in this case is that we want to intrude and retract. The more you intrude, the more you will be able to retract, because you are putting the incisors into a greater trough of alveolar bone. And what we plan to do when we do a maxillary dentoalveolar impaction, we would get a counterclockwise rotation of the mandibular plane angle, and therefore we should improve the chin prominence, reduce the anterior facial height, and would also reduce the gummy smile of this patient. So basically in this case, we plan to extract the 1-4, the 2-4, 3-4, and the 4-4. That's all 4 premolars. We want to intrude and retract the maxillary dentoalveolar segment, correct the spacing, bring about autorotation of the mandible to improve the chin prominence. That's like Leafort 1 osteotomy. That's close to Leafort 1 osteotomy that we expect. The only difference between Leafort 1 osteotomy and these type of cases is that you do Leafort 1 osteotomy in a single day. That's within a span of 2 to 3 hours during the orthodontic surgery procedure. But in this case, we would love to do it slowly. Okay, that's why we are doing with braces and dental implants, which is the TADS. And therefore, what we plan to do is slow impaction that is happening over a span of 8 to 10 months, avoiding the need for a more invasive procedure like orthodontic surgery, which most of the parents of these kids would not want to do. So there is a paradigm shift to the thinking. Only in cases which you find apt enough should you do and try such forms of treatment. A bit of proximal stripping might be required in the lower arch also, because there is a mild Bolton discrepancy which has a mandibular excess. If you want to go through these forms of treatment, this article is probably the best one, which would help you do it. That's Advanced Biomechanics for Total Arch Distalization and Hyperdivergent Facial Patterns by Ki-Joon Lee and Sunjin Kim. So what do we intend to do? Now, if you have something like such forms of problems, so the treatment planning is based on 3 dimensions. The one, if you go through this article by Chiolo Pike in the American Association of Orthodontics, the lecture in Philadelphia in 2013, the vertical maxillary excess corrections and anterior open bite corrections are based on 3 parameters. One is you need to intrude the molars and the maxillary segment with TADS. You want to extract premolars and the third molars if they are in occlusion, premolars for retraction and third molars to eliminate the terminal hinge. But in this case, we don't have a third molar which is in occlusion, and followed by clenching exercises after treatment so that you don't expect relapse at a later date, because all these patients usually have weak musculature because they are vertical growers. So basically, these clenching exercises at the end of the treatment are a part of the retention protocol that you would give, so that these don't recur over a span of time. So let's go forward with choosing the appliance. The appliance of our choice in this case is the Damon appliance. Now that's a semi-customized appliance system because it has a variable torque option. The more so of choosing this form of appliance or self-ligation appliance is basically because you can choose the torque value in such complex cases. It has better sliding efficiency because these are passive cell ligation brackets. And when you are doing big amount of tooth movement, the significant amount of retraction, then the sliding efficiency matters, because otherwise you delay the treatment by too long. Hygiene in these cases are mandatory, as you would see in this case, that when we are doing intrusion of the maxillary segment, you get a lot of punching out of gums. Okay, in those cases, that if you do have a self-ligation system, then it helps in maintenance of oral hygiene, and the complications are far lesser. So our choice of appliance is a self-ligation system which has a semi-customization option and better sliding efficacy, and that's the Damon appliance for you. So what is the torque consideration in this case? The torque considerations in this case is basically we have we have a standard torque system, a standard torque which we have chosen because there is a significant proclination of upper and lower anterior teeth, and therefore there is something like 3 options available for low torque, variable torque, and high torque brackets. Now, in this case, we chose a standard torque because we want controlled tipping of the incisors, because there is a lot of proclination of the upper and the lower anterior teeth. Now, when we look into the other part, the mandibular segment, we would like to use a standard torque in this case, which is a -6° torque. And what is the wire sequence for this form of treatment? Now, we usually place about 01690 for 30 days, followed by a 018 SS wire for about 1.5 months or so. Then you put him on a 1925 NiTi, but our working arch wire in this case is the 1925 SS. You do have to understand that all these movements are very complex movements and would require a rigid framework or rigid wire to have good control. Because if you are using TADS, if you're using multiple trajectories of forces, unless and until you have a very rigid wire, a rectangular wire in a rectangular slot, then you will have a lot of side effects which you really don't want, and your treatment is going to fail. So in this case, for all these cases, our option of wired is a 1925 SS in a 022 slot. You have a little bit of play, that's about 10 or 11 degrees of play, but that's acceptable, nothing more than that. And once we have intruded and retracted, since the occlusion is good, and at the end of the day, we would love to finish and settle the bite with a very thin wire. In the lower arch also, we would love to place the 90 a bit longer. We need to align and retract slowly level and align till we retract it with the 1925 SS2. In the lower arch, you do have an option if you don't want to retract with 1925 SS because you want to correct the IMP also, and a more control tipping is what is required. You can use a 1725 SS also. But however, in this case, we used a 1925 SS. So we used a 1925 posted, crimpable, hook, and inverted. So what is this? This is the intraoral pictures. These three pictures are very essential for an understanding of this case. Because if you see that we have placed a TAD between 5 and 6, that's between the second premolar and the first molar on either side. We also placed, that's for intrusion and retraction process. We also placed a TAD anterior to it. Okay, that's in the midline. If you see that the midline TAD is placed way high up, that's most of the TADs are usually placed in the attached gingiva, but in this case, we had placed it in the movable mucosa. Now, why is it so? Because you have to understand that we don't want to reposition the TAD again and again in severe cases. So when we placed a midline implant, we have to calculate where it needs to be placed. Now, the height of the screw or the TAD placement from the point of application of the force, that's the distance from the wire to the mini screw, has to be the amount of intrusion required or the amount of gummy smile you want to correct plus 2 millimeters. Why this plus 2 millimeters? It's only because, because in some cases when you are doing the treatment, you might feel that a couple of more 2 millimeters of intrusion is probably required. In that case, repositioning the TAD, is a problem to the patient. You have to do it, open up the old things. You have to reposition the TAD. You have to meddle with the soft tissue. As you can understand that as the intrusion happens, there is a lot of punching out of gingiva, which is bound to happen in such very severe cases where you're doing about 8 to 10 millimeters of intrusion. So ideally, you would love to place that anterior TAD only once. So in that case, it is better to use this formula, which is like height of the screw placement from the point of application of force is equal to the amount of intrusion required by you plus 2 millimeters, which is your leeway. You also have to understand that what is the amount of force that we are planning to give. So our archware for working archware is 1925 stainless steel wire. We have micro implants which are placed in the posteriors, which is about 1.5 into 8 millimeters. That's placed between the 5 and 6 region. The hook can be uprighted, if it's a short hook, but you need to see that there is a good amount of intrusive force that is applied to the posteriors also by the trajectory of the force that you are using. Here the hook is kept upright, but in certain cases you can invert the archware and give a more vertical component of force also from the posterior micro implant. So that's a micro implant in the posterior, and the force applied for the retraction process is about 180 to 200 grams on either side. Now that would give a retraction force for retraction of the incisors. It would also have an intrusive force because the trajectory of the force is coming from a vertical, the more vertical point. That is, the implant is placed slightly higher with respect to the hook. So if you want to have a more vertical trajectory, you can invert the archware also. So the net effect is that you get an extrusive component in the anteriors. But if you get an extrusive component in the anteriors, what happens is that your gumminess is planning to increase. But that's not what you want. You want the posterior gumminess to decrease and the anterior gumminess to decrease also. So therefore, you would add on one more screw, the anteriors. That is going to help you to intrude the anterior segment and to counteract the forces, extrusive forces that is applied that is coming from the posterior implant. So what is the amount of force that is required for anterior intrusion? It is about 80 to 90 grams of force. That's for all the 4 incisors together. Not more than that. If you still continue to give more than that, you might end up with a lot of root resorption in such complex cases. So the net effect of this system is basically the intrusion of the whole arch plus retraction of the anteriors. Now, if you look into the biomechanical perspectives, you would note that, okay, this is the first criteria, okay, in which probably an extraction of the third molar is required in certain cases where the intrusion is not happening, followed by a screw which is placed slightly higher than the point of application of the force so that you have a vertical component to it. But in this case, you would also note that you need to choose the appliance system wisely. So if you are using a standard torque bracket, that is which have a 14-degree torque in the anterior segment, you need to use a single screw, because a 14-degree torque would cause a lot of tipping of the incisors also. And if you use a single screw, then it has a little bit of intrusive effect, and it has a flaring effect to the incisors, because the point of application of the force is ahead of the CR of the anterior segment. So therefore, what you do is that the net effect is basically intrusion and a bit of flaring of the incisors, which counteracts for the 14-degree or the deficient torque that you apply have in the system. But if you are using a 22-degree torque bracket, probably a normal MBT bracket, it is advisable that you put 2 screws in the anteriors, because if you don't use 2 screws, you will have too much amount of flaring. Okay, so a single screw has little bit of flaring and a little bit of intrusion, while 2 screws mostly have intrusion and hardly any amount of flaring of the incisors, because you really don't need flaring because you already have a plus 22-degree of torque. So you can get a bit of control tipping in this case. So therefore, since in this case, we have chosen a Damon appliance with a standard torque bracket, which is 14-degree, we chose a single mini implant in the anteriors. While if you're using an MBT system, you might as well choose 2 mini implants, both placed distal to the lateral incisors on either side. That is the area of the CR of the anterior segment, and that would give you true intrusion. So your appliance and force configurations has to go parallelly, and you should understand both of them before you choose the system. So that's what exactly happens. So the counterclockwise moment is very less when you're using 2 screws. It's basically intrusion. Now let us see some problems which arose because because we are doing about 8 to 10 millimeters of intrusion in this case. What is the problem that comes? Whenever you are intruding, you need to understand the bone biology well, and you need to understand the soft tissue biology well too. As we have read in our good old textbook of Profit and Graeber, is that okay? Bone remodeling takes faster, is always faster, but the soft tissue remodeling is always slower. Now, when you have a lot of gingiva in the anteriors because you have a severe vertical maxillary excess and you want to intrude by about 8 to 10 millimeters, the biggest problem that happens in most cases is that you have a lot of punching of gingiva which happens. What is punching of gingiva? You get a lot of pseudo pockets that come up whenever you are doing. So therefore, the calculation of the amount of intrusion to be done is supposed to be done on day 1. Because if you try to calculate at this point of time, then it's an arbitrary calculation because your gingiva has overgrown during the process of intrusion. So now that we had calculated initially and placed the screw accordingly, what we need to do in this case is to eliminate the pseudo pockets, because that's not periodontally good also, apart from the fact that you need to give a true picture to the patient as to amount of gummy smile that is corrected. So pseudo pocket elimination is by determining the probing depth minus normal circular depth of 1 to 3 millimeters. So that's the amount of gingivectomy that you need to do. So you can use a CPITN probe to check the amount, to check the probing depth of each areas, and you can minus it by 1 to 3 millimeters to get the amount of pseudo pocket that needs to be eliminated. So you need to get this lasers done in very severe cases, because unless and until you do the lasers, you will not get the true replica of the amount of gummy smile that you have corrected by intruding the anteriors within the bone. So that's the anteriors that needs to be lasered off. and you can use a diode laser. We prefer a diode laser with, not more than 3 to 4 watts for getting a gingivectomy done, or your periodontist can help you out in this process. So the final results of the treatment runs like this: is class 1, the molars and class 1 canines to finish with. Ideal overjet, overbite, midline perfectly matching, apart from the fact that you have corrected 100% deep bite also, because the patient was having a palatal trauma initially. So at the end of the day, the midlines and all are matching. That's great with respect to the final finish of occlusion in a very severe case. And you did a bit of gingivectomy with lasers. So the correction of spacing and proclination is already done. So what is the final result with respect to the occlusal parameters? We see that you have corrected the spacing and proclination of the upper anterior teeth. You have corrected the spacing and proclination of the lower anterior teeth also. And you placed a BLR in both the upper and the lower anteriors because it's a case of spacing. So you really don't want relapse to happen. I prefer a BLR both in the upper and the lower anteriors, apart from labial bow shoulder to Adams, which is a modified Holly appliance for the upper. And you can see that we have placed the BLR from premolar to premolar in the lower to avoid opening of the extraction spaces, because all these biomaxillary protrusion cases, most of them have large tongue or a more anterior postural positioning of the tongue. So the relapse would be high if at all you are not giving a fixed bonded lingual retainer. So this is the final result, an absolute fabulous result to end with, as we believe that is not done surgically. The patient is midline is perfectly, almost close to perfectly on. She has a consonant smile arc. The gummy smile is completely gone. We would go into details and compare the pre-op and the post-op in the subsequent slides. But the smile aesthetics have drastically improved in this case. So when we look at the 45-degree view, we understand that the amount of intrusion that we would have done, that's about 8-9 millimeters of posterior intrusion that we corrected, apart from correction of proclination of the upper and the lower anterior teeth. And we have a perfect profile to end with good nose and chin prominence. And a relationship with the E line is almost close to perfect. So it's an orthogonal facial profile that we got at the end of the day. So let us critically appraise the OPG. We know that we have got a huge amount of intrusion. We did get a blunting of root, although minor, maybe about 10%. That's perfectly acceptable so long as we have avoided the surgery, and we have checked about with respect to the Anti's law, the amount of crown and root proportion with respect to the bone morphology which is there in the OPG, and this is perfectly acceptable. Okay? That's minor root reduction after 9 mm of anterior and posterior intrusion. That's quite severe. We wanted the patient to prophylactically extract the 3/8 and the 4/8, but since it did not pose a problem with the patient and it was asymptomatic, she avoided it. And mostly since the third molar is not in occlusion, the upper third molars are missing also. That should not, the lower third molar should not create a problem. But still, the advice was given, and the patient would opt for it at a later date. I mean, look at the cephalometry. We see that there is the proclination of the upper and the lower anterior teeth has grossly improved. The interincisal angle is almost close to perfect. The nasolabial angle, the chin prominence, the profile looks excellent at the end of the day. So that's superimposition with respect to the face. This is the result we didn't even expect at the initial starting of the treatment. Now the SNA, SNB and all are all within limits. Apart from the fact that the interincisal angle has grossly improved, the overbite is almost gone, the overjet is grossly increased. We now have an FMA of 25 degrees, which is like shows that we have got good amount of counterclockwise rotation of the mandibular plane. That's great. The nasolabial angle is all fine. So what is the net result that we got? Is a class 1 skeletal base, an average growth pattern, normal inclination of the upper and the lower incisors, and the orthogonal facial profile. With respect to the gummy smile, we corrected it quite a lot of gummy smile was there. The anterior gumminess reduced to about 35 millimeters. The maxillary posterior dental height reduced quite a lot to 24. So this is close to orthodontic surgery that we got. So how did the treatment progress? It progressed from a class 1 skeletal base bimaxillary protrusion with spacing to use of 3 mini implants. And we got a bit of auto rotation with the 3 mini implants also. If you are not getting a good amount of auto rotation, it is advisable that you place the screws in the lower posterior segment also, because sometimes what happens is that when the anterior and the upper arch is intruding, there is passive extrusion of the lower arch, lower posteriors, in order to establish the bite. And then it's the dental movements that are taking place, and the counterclockwise rotation of the mandibular plane is never taking place. So if you see that, in that case, you need to hold on to the passive extrusion of the first molars in the lower arch and the second molars in the lower arch. So at that point of time, you need to place screws in the lower posterior segment also. Now, at the end of the day, we got a beautiful result with class 1 molars and class 1 canine relationship. Now, when we look into the anterior aspects, we see 100% deep bite, which is corrected. That's the pure intrusion of the anterior segment, which has corrected the deep overbite. The midline is perfectly on, is matching now. The beautiful architecture of the gums after the laser is done. And it's done pretty well. You can see a lot of attached gingiva, no marginal discrepancies. Okay, and good architecture of the gums are visible. And basically both the upper and the lower arch are within good trough of alveolar bone. So what is the comparison? When we compare, we see that a lot of proclination of the upper incisors were there. Initially, we had increased incisor show at rest, which was grossly corrected. 100% deep bite was also corrected, and we can see a completely different face at the end of the day. Lip competency has been established. Lip strain, which was there, is no more there at the end of the treatment. Incisor show at rest is definitely improved at the end of the day. So that's a changed person as such. So when you look at the gummy smile, we are astonished to see that the amount of posterior and anterior gumminess that we had corrected with minimum amount of root reduction, which is perfectly acceptable in case of orthodontic treatment. So we had a gummy smile which was attended to both in the anteriors as well as in the posteriors. So the maxillary anterior dental height reduced from 44 to 35. That's about 9 mm of intrusion that we got in the anterior segment. So when you look at the 45-degree view, you will be astonished to see the amount of posterior gumminess that we corrected, and a changed person as such at the end of the treatment, where proclination of the upper and the lower anteriors were corrected, apart from the fact that posterior gumminess was also taken care of, anterior gumminess was also taken care of. So that's gummy smile corrected, vertical maxillary excess taken care of. So the posterior gumminess reduced from and the posterior dental height reduced from 44 to 35. That's anterior, and the posterior one reduced by about 5-6 millimeters from 28 to 24. Now, when we look at the profile, we see that there is acute nasolabial angle. It's a convex facial profile, a lot of incompetency of lip, but at the end of the day, she has a very balanced facial profile with the nose prominent, chin prominent. You can see the amount of retraction and lip changes that we got at the end of the treatment. That's convexity of the profile which was corrected. So when you look at the pre-treatment and post-treatment comparison of lateral ceph, we see that the interincisal angle has drastically improved. Okay, we got a lot of intrusion. You can see that where the incisors were placed with respect to the alveolar bone and how much amount of intrusion we got at the end of the day, both in the anterior as well as in the posterior segment. And this is ample evidence of the fact that orthodontic surgery like orthodontics is here to stay. Because if you can eliminate the morbidity of a Leafort 1 osteotomy by this form of treatment, this is bound to stay, and many patients are willing to take these form of treatment rather than opt for a surgical option. But not every time can you neglect a surgery. Okay, we have to understand the amount of intrusion possible in every case, whether the root tip is close to the NF line or not, how much amount of intrusion is for all this analysis is very, very important for the success of these cases. Not every case can be treated without surgery, but when you analyze and diagnose them well, you will know which cases are to be treated non-surgically and which can be treated surgically. Because whatever said and done, if the tip of the incisor is very close to the NF line, that is the cortical bone of the palate, intrusion is definitely not possible. But if you see in this case, there is a lot of alveolar bone trough that was present for the intrusion and retraction of the incisors, favorable case for orthodontic surgery like orthodontics. If you want to go into details and understand the biomechanics of each case, you can go through this article written by us in the Journal of Indian Orthodontic Society, which talks about correction of gummy smile and VME on TAD transparent arch modified combination system, an effective tool in the non-surgical management of individuals with vertical facial patterns and gummy smiles. You can also go through this the book by Kwan Chol Choi, which talks about intrusive retraction mechanics. That is going to give you a very good idea about the same. If you feel that you gained really good information out of these lectures that we are putting up in YouTube, do press on the subscribe button below and subscribe to our channel so that you get updated about the recent trends in orthodontics and the tough cases that we are treating in our clinical practice. You can always contact me in this number or WhatsApp so that we can clear our doubts for you. Okay, we can add you to groups in which we discuss clinical content. You can also follow us in Instagram at GLOC Imperial Clinic about the cases that we finish in day-to-day practice, and you will be able to contact us and discuss in details about how we are doing such forms of treatment.